with us and look forward to your questions and feedback on the presentation. Before I turn it over to Dr. Dan Rubin, Chief Medical Officer and co-founder at LogicStream, I wanted to let you know you can type your questions into the chat window during the presentation, and we'll get to as many of them as we can at the end. Thanks again for joining us, and Dan, take it away.
Thanks, Scott. So as Scott mentioned, we're here today to talk about unnecessary variation in care. A little bit about my background. I am a pediatrician by training. I practiced in primary care pediatrics and urgent care for a number of years before going back to school for health informatics. Got my master's at the University of Minnesota, went over to industry to work on some advanced clinical decision support solutions and integrating those solutions into the electronic health record. I've done a lot of work on process improvement and decision support to improve quality and reduce costs. And as Scott mentioned, I'm the co-founder and chief medical officer of LogicStream Health. So we're going to talk about unnecessary care variation. We'll define the problem. We'll explore root causes, look at some potential solutions, and then we should have some time at the end for Q&A. So when we look at unnecessary care variation, we'll use a very simple definition for this. So just care that varies from accepted norms without a good reason. So very simple. And when we look at different types of unnecessary care variation, really we can put it into two main categories. One would be errors of omission, so failing to provide care that meets accepted standards. Examples of this would be not ordering a colonoscopy at the recommended interval for a patient, not having a hemoglobin A1C done on a diabetic within the recommended interval. And these things are typically potentially harmful. Accepted standards are in place for a reason, and when we deviate from those standards, potentially we cause harm to patients either in the short term or potentially the long term. Errors of commission is the other category, so providing care that does not meet accepted standards. So examples of that would be putting a patient, prescribing amoxicillin for a patient who's penicillin allergic, putting a patient on anticoagulant medication after surgery for venous thromboembolism prophylaxis when in fact all that's indicated for that specific patient is TED stockings. Those examples are potentially harmful. There are also examples that are harmless but wasteful. Examples of that would be ordering daily CBCs on patients in the hospital that don't really need that, where it's not indicated, ordering an MRI on simple ankle sprain, uncomplicated ankle sprain. So those examples, you're not necessarily doing any harm to the patient, but it is wasteful of resources. So we're going to run through some research, a study from the ABIM and Robert Wood Johnson Foundation. It's a survey of 600 providers asked about ordering unnecessary tests and procedures in response to patient requests. And just to frame this, we are going to look through this study in some detail and give some statistics. Following that, we're going to get into some potential solutions for unnecessary variation in care. Those solutions will be around all different types of unnecessary variation. So the solutions are not specific necessarily only to ordering unnecessary tests and procedures. But we thought this research would be interesting to present today as examples of unnecessary variation and why it occurs. So when it comes to ordering unnecessary tests and procedures in response to patient requests, nearly 75% of providers recognize this as a serious problem. So docs know that this is a big deal. It happens very frequently, so almost 50% are asked to order unnecessary tests or procedures at least once a week. When we look at how docs respond or clinicians respond to these requests, 40% will refuse the test if they believe it's unnecessary, but more than half will order it anyway. They'll advise against it, but order it anyway. So it's fairly common for clinicians to place these orders for things they believe are unnecessary. When asked about the underlying reasons for doing so, most of the top reasons revolved around kind of safety and security of the doctor, the clinician themselves. So malpractice is the leading reason. Just doing it as the safer option is the next leading, and the third leading reason is just for reassurance. Clinicians are trying. They will outline the reasons why tests are unnecessary most of the time, so 87% of the time. They will outline the reasons tests and procedures are unnecessary. And they are in cost discussion with patients at least some of the time. So 41% will always or often discuss the cost of a procedure. And providers do believe that they are responsible for helping to eliminate this problem. Fully 2/3 believe they bear a great deal of responsibility for eliminating unnecessary tests and procedures. When asked who they believe is in the best position to fix the problem, most physicians believe that they themselves are in the best position to fix this issue. So now, as I mentioned earlier, we're going to get into some potential solutions. And again, these solutions don't just revolve around the ordering of unnecessary tests and procedures, but really for any unnecessary variation in care they apply. And we'll start this off by looking at a version of the triple aim. This version of the triple aim is really for at the individual hospital level, hospital or health system or clinic. What are these groups seeking when they look to reduce unnecessary variation in care? So typically they're looking for three things. They're looking to standardize care. They're looking for physician acceptance of that standardized care, so that change in workflow, whatever changes to further standardized care, they want their docs to accept it, and they want to get a good value, so the lowest cost for the greatest standardization that they can achieve. So looking at solutions to reach those aims, we'll talk about two strategies. So care management strategy. So typically this would involve hiring up or rededicating resources to manage care. An example of this would be for diabetics who haven't had their hemoglobin A1C in the suggested interval. You could generate a list of patients that fall outside the recommended interval. You could have care managers, nurses, other folks reach out to those patients, schedule those appointments and have them come in for that test. They could also bring them in for any other diabetes care that they fall outside the recommendations on. This method tends to be fairly resource intensive because you do have to hire these people or rededicate resources from other areas to work under this new care model, but it can be very effective. Clinical decision support is another method. So for this example with the hemoglobin A1C, you could build an alert into the electronic health record that whenever a patient who is outside the recommended interval for their A1C comes in to any part of your health system, that provider is reminded that they need this test. You can provide an easy path from that alert for the provider to order that test and provide in that alert that the result go back to the patient's primary care physician so that the person ordering it does not need to concern themselves with following up on the result. With that, you've created decision support and a workflow. What's key at that point is to measure how well that decision support and workflow is working and to really iterate on that, optimize it so that it's as specific and sensitive as possible, working exactly as you want it to drive that outcome. Typically, this approach requires less resources, so a smaller number of people to implement. We'll look at that a little bit more on subsequent slides. So when we compare these solutions, care management is typically used more for errors of omission, again, so for potentially recommended screening tests. as we mentioned earlier, for getting people scheduled for chronic care. There are other ways to use care management in other ways, but primarily that's how it's used. Clinical decision support is used for both errors of omission and commission for that patient where the clinician tried to prescribe amoxicillin when they're penicillin allergic. You can have decision support set up to catch that error and alert the doctor so that order doesn't get placed. Under a care management model, obviously that's more challenging. So when we compare these solutions further, looking at care management, there tends to be a significant initial cost, as we discussed earlier, to bringing those resources on board to work under this care management model. That cost also tends to be an ongoing cost. Those diabetics don't necessarily come in for their A1Cs on an ongoing basis based on that initial reminder that they received some time ago. So on an ongoing basis, you need to be reaching out to those patients to work with them and reach your quality goals. Clinical decision support tends to have a somewhat smaller initial cost, as we discussed earlier, but where the difference is most stark is on an ongoing basis. Once that decision support and workflow is in place, it's essentially working in the background for you on an ongoing basis with minimal ongoing costs, really some cost to monitor it, but that's a very low resource spend in a relative sense. When we look at domain complexity, however, clinical decision support tends to be a more complex area. Care management does have some complexity to it, certainly. Setting up those models and processes properly to manage care is somewhat complex, but clinical decision support requires domain knowledge of both the electronic health record, of clinical care and processes around clinical care, as well as around data, and all those domains need to really come together for clinical decision support to work properly. There are tools and solutions that can help reduce that burden, that complexity, but it is still a complex area. They're both approaches can be very effective, and certainly there are some differences in the areas where they can be most effective, but they both certainly have a role. We're going to look a little bit more at care standardization through clinical decision support. We're going to look at a case study around venous thromboembolism prevention. So this is a study based on just under 5,000 surgical cases. So 2,600 or so had use of a standard venous thromboembolism prevention protocol. Another 2,000 had venous thromboembolism clinical decision support with workflow that had been measured and optimized for effectiveness. And in comparing those two groups, the standard protocol, there were 39 surgical VTE events that occurred in those patients. In the measured, optimized clinical decision support supported protocol, there were only 12 surgical VTEs. And this represented an 88% reduction, which was statistically significant at a p-value of 0.002, so highly statistically significant. And so if we're to extrapolate these results to a moderate-sized health system across within 1 year, we would expect the elimination of 563, 40 lives and almost $7 million. And again, the exciting thing about this is that once the solution is in place, there's really minimal spend to maintain. I should mention that this health system where the case study was done did not have a particularly high rate of VTE. They actually were a fair amount below the national average. They had about a 1.5% rate prior to this intervention taking place, and it dropped to 0.5% after the CDS was in place. And when we look further at care standardization using clinical decision support, typically when an electronic health record is implemented, there is a gap between the current process that care providers are using to provide care and the electronic health record. And so to achieve results like those that I showed on the previous slides, you really have to fill this gap in, as was done in that study, with standard workflow and with clinical decision support. And so when those two things are done together effectively, you can drive really great and scalable results through CDS. But what do you need to drive those results, to fill in that gap? So to get to that standard workflow and CDS that's working properly, there's three things that you need typically. You need a CMIO or someone with clinical informatics expertise to help with that domain knowledge. You typically need a measurement tool set of some kind. Measurement of that clinical decision support and workflow is critical, both for making the CDS as effective as possible to get those great results that we're working toward, but also in order to have physicians accept this change, because you really need that CDS to be working seamlessly and really targeted on the folks that can make a difference. And when it is not targeted is when typically you'll have problems with physician acceptance. And then you need optimization. So once you've measured it, really building that workflow up, making it better and better, making that decision support better and better until it is highly sensitive and specific and working in exactly the way you need it to reach quality improvement goals. And so with these three parts in place, you really can reach these goals of care standardization with physician acceptance and with low cost. And so to look at key lessons from this discussion today, both care management and clinical decision support, both those approaches have a role and both can be effective in reducing unnecessary variation in care. Clinical decision support requires more tools and expertise, but it is typically more resource efficient, especially in the long run. Partner with your CMIOs. They're there to help and can help you reach your goals in terms of reducing unnecessary variation in care. Measurement and optimization are really key to effectiveness and physician acceptance of decision support and the workflows that support that decision support. So with that, we'll move on to see if there are any questions.
All right. Thanks for sending in your questions. We're going to take a look at a few of them and see how many we can get to here in the next few minutes. The first one, how do I partner with my CMIO to determine what can be done to reduce unnecessary variation in care?
So I think that's a good question. You know, typically what we've seen at organizations is that, you know, once you have your quality goal, once you have your either cost containment or quality goal in place, CMIOs typically are receptive to helping to reach that goal. They're typically aware of the different techniques using decision support that can support that. I think what's key is that there be those lines of communication open and that close working relationship with the CMIO to really advance those goals. So I think, you know, the key is just to talk to them about the goals you have, and then it should be relatively easy to move forward from there.
Okay. We had another one come in right at the end. Can you explain more about what you mean by optimization and measurement and why those are really keys to standardizing care?
So optimization, again, it's really the process of making sure that the decision support that's in place is as sensitive and specific as possible. So really putting in, once you put in decision support, typically it is not going to work perfectly the first time. In fact, it never does. And so by measuring that CDS and making sure that it's working properly and targeting the individuals that you need it to, you are essentially limiting the folks that see the CDS in their workflow to those that really can be helped by it. So an example of this, one organization that we've worked with had clinical decision support around ACE-ARB therapy and initiating ACE-ARB therapy in failure patients. What we found when that decision support was measured was that an alert about ACE-ARB therapy was showing up in the pediatrics clinic and was showing up in the mental health clinic and showing up to the radiologist. And there wasn't really a workflow in place supporting that, that an order for an ACE-ARB be placed in those locations, and really it wasn't appropriate for that to happen in those locations, yet those people were seeing that alert every day. And so that's what I mean by making it sensitive and specific. You really want it to only show up to the people who can act on the decision support in a meaningful way.
Okay. Another question that came in, how does LogicStream help with standardizing care, and how do you help health systems make that a reality?
So where we come in is the measurement and optimization part. So we talked a little bit about how that can reduce some of the burden of domain knowledge because it presents, we present information in a very easy to digest and useful way to allow organizations to measure and optimize clinical decision support. And really that is the focus of where we come in, that measurement and that optimization, which we found from working in the field for many years is critical, and it's also very complex and difficult. And so we have a solution that makes that measurement and optimization much easier and really feeds into that that optimization phase so that you can get your CDS highly standardized and highly effective.
All right. I think the last question that we have time for today, you talked about some CDS tools, and it looks like someone brought in, can you explain more about what those tools are and what might be available to health systems?
Sure. So when we talk about what some of the CDS tools are that are available, it's really there's a broad range out there. So I talked about alerts a lot because that is really the most straightforward example. But there are many other decision support tools besides alerts. So order sets and subparts of order sets are also a very powerful tool. So lists of standard orders that should be ordered in certain scenarios or for certain conditions. And those can be also used to influence clinician behavior and reduce unnecessary variation in care. Things like documentation templates can also be useful. There are also many other clinical decision support tools, but those are some of the main ones that are in use.
All right. That's all the time we have for questions today. Thanks again, everyone, for joining us. And be sure to look for a follow-up email arriving this afternoon. In that email will be a link to more in-depth information related to the VTE case study Dr. Rubin discussed during the presentation. Also, if you asked a question we weren't able to get to, we'll be following up directly with you very soon. Finally, if you have any additional questions or feedback, we'd love to hear it, so please send that to me. And my email address is scott@logic-stream.net. Have a great day.